Welcome back, everybody, to another lecture in physics. We're getting so close to done here. We're on chapter 22. We're going to go over quality assurance. So quality assurance program needs to be done routinely and periodically. So it doesn't mean, oh, look, we got an opening in our schedule. Let's just do some quality assurance on our machines. And maybe we'll do it in a couple weeks because we have more time, or maybe we'll do it in 3 years. Maybe we'll do it never. I don't know. No, it needs to be routine and periodic. So we need to pick a time. We're going to do it 7 a.m. in the morning every 6 months. That's your routine and periodic. You want to make sure that you're scheduling for these. You want to make sure that you are blocking your schedule so you have time to perform these routine and periodic maintenance programs on your machine. So routine and periodic is the key to a good quality assurance program. Now with quality assurance programs, they are going to ensure a few things. First, they're going to ensure that you have optimal image quality. By performing quality assurance, we are going through the machine controls, we're looking at the computers, we're looking at the mechanical pieces of the machine, making sure that it's all in operating order. Therefore, we get the best images that our machine can produce. Now, another thing it's going to do is reduce downtime. And that might seem odd at first, thinking, well, you're blocking the schedule, you have to make sure you have access to the machine. Well, no, it actually does reduce downtime, because if you're scanning a patient and you realize your machine doesn't work, it takes a lot longer to get biomed in there or get a physicist in there to look at your machine. It takes more energy to cancel all those patients because now you're down the machine. So it's really important that we are catching any of those small things sooner so we can fix them when we have the time versus having it be kind of like an emergency later on. The other thing with quality assurance, especially in any sort of medical field, hospital, clinic, any of those settings, they are actually legally required. And part of the legal requirements are to keep records of everything. So you will most likely not have a whole lot to do with this as the sonographer, but your biomed department at the hospital is going to keep all the records, all the paperwork of what they did during their quality assurance checks. Now, something that you might be a little bit more familiar with as the sonographer are checking your room, making sure that like your oxygen and your suction tank are working. You'll be responsible for checking that your cleaning device for the probes, be it a Trophon or Sidex, which is a cleaning solution, making sure that's all up to par. Making sure that your oxygen tanks all have oxygen in them. There's a lot of things that are done in the hospital or in the clinical setting that are checked to make sure that we are following guidelines. We're doing it routinely, we're doing it periodically. So when an accident happens in the hospital, because they will, it truly is an accident. It was not a foreseeable accident. It wasn't something that could be avoided. So legally required, you're going to do lots of documentation on the equipment, making sure that we are following the routine and periodic quality assurance program. Now, I mentioned a couple times biomed department. Biomed is a department within the hospital that usually learns all of the equipment in the hospital, the IV machines, the dialysis machines, the respiratory vents, our ultrasound machines, x-ray, CT, all of it. These guys are good and they know what they're doing. They learn how to fix these machines. They learn how to troubleshoot them, how to do the quality assurance on them. And so they're usually the ones that'll take care of the quality assurance. If you work in a smaller hospital or possibly in a clinic, you might actually be responsible for some of these roles. So it's important that we know kind of the basis of a quality assurance program and why we do them. Now, quality assurance program is going to have 4 requirements. The first one is that we need to assess the system components. So there isn't much of a quality assurance program if we don't make sure that our machine is in quality operation. So we want to make sure that we're going through all the system components, making sure all the transducers work, making sure the keyboards work, the knobs, the articulating arm of the display, that the CD-ROM works, the USB works, the wheels work, the locks work, all of it needs to be checked. And there's usually going to be a check-off list. You want to make sure that you use that check-off list. It'll be your records that you'll want to keep. Make sure that you get everything, keeping that routine and periodic portion of the quality assurance going. If you were to find anything abnormal within that check, then you're going to do repairs. So if a fan is broken, repair it. If a transducer is broken, send it out to be repaired, so on. We also want to make sure that we're performing preventative maintenance. This might actually be something that you'll be responsible for in the department. There are fans in our machines that help keep everything cool on the inside, but they do suck in air. And as they suck in air, they kind of suck in all like the little fuzzy dusty particles in the air as well. And there are vent covers or filters that need to be vacuumed. And if we don't vacuum those out, the machine can overheat and cause problems. So performing preventative maintenance like vacuuming out the filters, or sometimes our trackball gets really gross from gel getting on it and it doesn't work very well. It gets kind of jumpy. Cleaning that trackball is preventative maintenance before it breaks. So we want to take care of our machines, cleaning it, making sure that everything is operational before something actually has to be repaired. And then, as we mentioned before, quality assurance programs are a legal necessity. We prove that we are meeting that legal necessity by keeping records. When was the maintenance check done? What was fixed? What did we find? Just keeping records of everything is going to be very important. When creating a quality assurance program, we want to make sure that we are keeping these 5 goals in mind. The first one is to, again, guarantee proper operation of the system. That is like number 1 goal here for everything. Make sure that our system is working appropriately. Make sure that it's creating diagnostic images. We also want to use the quality assurance program to detect gradual changes. So we always are going to check the machine under certain guidelines. We're going to use the same transducer. We're going to use the same output power. We're going to use the same phantoms. We're going to use the same everything. We just want to try to control the environment that we are testing the machine under. Another goal of the quality assurance program then is to minimize downtime. We talked about this. If we can catch those defects, those kind of small gradual changes early, and we can fix them early, it's better to do it as a planned maintenance versus reactive maintenance, as emergency maintenance. It'll also reduce the number of non-diagnostic exams. I have been working on machines in the past in which it's called an ABI machine, and basically it just has like a bunch of blood pressure cuffs on it. And sometimes those blood pressure cuffs, the seals on them get loose and then they don't inflate. And if they don't inflate, we can't get a good reading on the patient's blood pressure. So these blood pressure cuffs, because they don't work, we can't get a diagnostic exam. Had the quality assurance program caught that, those seals could have been replaced long before we had a patient on the table getting that non-diagnostic exam. So again, checking all those system components are going to help us to reduce the number of non-diagnostic exams because we know our equipment is operating appropriately. Lastly, then, it'll also reduce the number of repeat exams. Kind of the same idea with the non-diagnostic exams. If that's not diagnostic, they need the exam done again. And if you don't have a backup machine, then you can't just repeat it right on the spot. So the patient needs to be rescheduled. That takes a spot from a new patient. That delays the patient's care, makes the providers angry. Just not good practice. So a good quality assurance program is really going to help your department run much smoother. Now, when we are looking at our machine, I had mentioned that we want to recreate the same environment for every quality assurance check that we are doing. And we can check the machine components by using what we call phantoms. And so the 3 most common phantoms that we use are a tissue equivalent phantom, a Doppler phantom, or a beam profile, also known as a slice thickness phantom. Now, these are going to be tools that'll be kept in the ultrasound department, in the biomed department, or with the physicist. They're going to bring them to the quality assurance check, and they're going to use them to evaluate the machine components. We'll make sure to spend a little bit of time discussing each of these in a little bit here. To highlight one of the concepts we've already kind of talked about, this slide goes a little bit further, again reminding us that we want to create a quality assurance program that uses the same environment to test the components of the machine. So we want to make sure that we are testing under known defined conditions. That's where using those phantoms comes in handy. We're not using Bob, the janitor, 1 week, and then we're using Cindy, the receptionist, and the next time we do quality assurance. We're going to use something that is consistent and won't change over time. We also want to use constant instrument settings, so it's unhelpful if we do all of our QA using the adult echo setting on our machine, and then the next time we do it, we decide to do first trimester OB with a different transducer. Like that doesn't help us. That doesn't tell us has anything changed since the first time to the next time that we do the quality assurance. So we want to use constant instrument settings. Using a phantom with measurable characteristics is going to help us to identify what we should be able to see. The phantom tells you exactly what should be seen, and then we can use the machine settings to make sure that nothing changes from time to time as we are trying to view those objects in the phantom. Again, we'll talk a little bit about this more in a second here. And then lastly, we want to image in an identical environment. If you could set everything up, ideally it would be the same temperature, the same time, the same humidity, the everything. That's not always realistic, but you don't want to move the machine into a really bright room where maybe you have to adjust some settings so you can see a little bit better compared to a really dark room. So you should always be maybe having the lights at the same level. Try having the same person doing it each time so they can see those changes as they are going through the quality assurance checklist. So speaking of having the same person do things and having that checklist, there is actually an idea that we need to kind of discuss, and that is objective versus subjective standards. So we need to know what objective standards are, and we need to know what subjective standards are, and why we prefer one over the other when creating a quality assurance program. So objective basically means that it's unbiased, it's factual, repeatable, and that you'll get the same results no matter what. Compare that then to subjective standards. Little leggy here, sorry about that. So compare that to subjective standards. We are looking at subjective, meaning there's perspective to it. We can't verify it. It's opinion based, and it might vary from person to person. So again, objective is going to be very standard. It's going to be protocol. It's going to be factual. The most important part, it's going to be repeatable. Compare that then to subjective, where it's opinion based. It might vary from person to person. So one thing, comparison wise for subjective, you'll see as sonographers that people like to image at different brightnesses and darknesses, and they have a certain perception of how the machine is operating for them. So one sonographer might come back and say, that machine in room 1 is acting really finicky. I feel like I can't get the gain to go dark enough. And another person might go in and be like, oh, this machine is so dark, I can't stand it. And so that's where that subjective part comes in. It's really up to the opinion of the person. Compare that to objective then, where we use our phantoms, and the phantom says there should be 5 pins displayed. If your machine shows 5 pins, you're good to go. If it doesn't, you're not questioning, am I just not seeing this, or is this just a matter of opinion? This is factual. There's only 4 there. So we want our quality assurance programs to be objective. It is important for maintaining integrity of the equipment. So as promised, we're going to talk about the phantoms. The first one that we're going to talk about is the tissue equivalent phantom. So the tissue equivalent phantoms, or the TEPs, have very specific qualities about them. First off, they need to be made of a material that allows sound to travel at 1540 meters per second. We want that 1540 meters per second to match up with what we expect sound to travel at in the soft tissue of the body. Secondly, we need that soft tissue phantom to have some attenuation within it. We know that the body is going to attenuate, so we want to recreate what the sound is going to interact, or how the sound is going to interact with an actual human. We also need to have some materials within the tissue or within the phantom that are going to cause reflections. So maybe little pins, maybe there's some cylinders in there. We want it to have measurable characteristics within the soft tissue phantom. And then lastly, we do need some echogenicity. We do need it to kind of mimic what soft tissue looks like. We don't want it just to be anechoic all the way through with some random pins in it. We want it to really kind of just give us the feel of actually imaging within the body. So here I have an example of a tissue equivalent phantom, and what you will see on it is a area up on top here. This is where the transducer will come in contact with the tissue equivalent material. The material is usually kind of like a little jelly material. It's kind of squishy. If you think of like ballistics, gun ballistics, the stuff that they shoot into is very similar to what this is made out of. So it's kind of like a stiff jelly. And then on the front of it here, part is very important. This front part is kind of a map as to what is inside of it. So if you were to look down through this window up here, you can't actually see these materials, but when you're scanning, you can see the material. And so when we are scanning, we want a roadmap to what's inside. So when we scan and see maybe only 4 pins at the top here, we know we should be seeing 5. We then can see that we know these pins going vertically, how many there should be, how far apart they should be. There's usually some sort of measurement distance in there. We know that we should be able to see cylinders of different structures going down. We know what these should all measure. So this will help us test lots of different things. And we're going to go over kind of point by point on this map here. When you put the transducer on this tissue equivalent, you get a picture that kind of looks like this then. So we're using the curvilinear probe. We're at the top of the tissue equivalent here using gel, just like we would. We can see some little dots right here. These are going to tell us our dead zone. These vertical dots tell us what the vertical registration is. These are going to tell us a little bit about axial and lateral resolution. We have horizontal registration. And again, we're going to go over all these in detail. We have a little bit more about, are we seeing anechoic structures all the way through? So lots of things that we can test with that tissue phantom. And I'm going to spare you guys the pain of watching me try to scan a tissue phantom, but I do have one. So I have one here just to kind of show you. This is a little close, so I apologize. I don't know if we're going to get much better here. But again, we can see the roadmap to it. This is showing us that there are 8mm structures, 6, 4, 3, and 2mm structures. A lot of times we can't see less than 2mm with ultrasound, so this will help us to tell us, are we seeing that small? We can see different structures that are going to be very echogenic up at the top here compared to something that should be anechoic at the bottom. Are we registering the right echogenicities through there? This horizontal scan group here tells us, there should be 1, 2, 3, 4, 5 pins visible in the far field in the horizontal position. We then know too that they should each be 2 centimeters apart. That is something we can measure. So this roadmap on the front here is super helpful for knowing what's in there to then test, are we getting the right measurements, the right echogenicities, the right number of things being displayed. I'm going to flip it up here. This is the top of the tissue phantom. It's a little dusty, it's gross. But you put the probe right onto this with a little bit of gel, and then that's where we're going to be able to see all of those structures from within side. This one has open sides on all of it, so we can scan from this side. The first thing that we're going to see then are these bars, so that'll help us to visualize from left to right. Are we getting the right eccentricities through here? We can scan from this side if we want to check things down on that side. We can scan from this side. This is again going to help us look at a little bit more of our resolution line that's displayed here. So these are surprisingly heavy. Like I said, you can't really see into it. So that's kind of nice that you can't see into it. You have to rely on using the ultrasound machine to be able to look at this. But yeah, usually the physicist or biomed department is going to have this on hand to test the equipment. So going back to that map, this is one that I found online. This one is actually very similar to the one that I was just showing you on the front of the tissue phantom that I have. And if I get a chance, maybe I will get a chance to post a painful video of it. I just don't have a good way to record my screen, so that's the part that kind of bums me out. But anyway, moving on. So we need to understand what all of these symbols are, what they're telling us, what we can evaluate in that area. So you should have a picture of this in your notes. We'll also go over a lot of these portions kind of bit by bit in the part to follow all the phantom stuff, but we'll just cover this again real quick and then we'll revisit it in the second part of this lecture just so we can hear it a couple times because it's going to be on your test. What do these items tell you? All right, so let's start with the dead zone. The dead zone is this first part up here. Let's get up my pointer here. All right, so we have the dead zone. And what the dead zone tells us is how deep into those first few centimeters of our picture, how much of it are we just missing? Remember, we have speckle right at the top part of the image, and that's going to degrade our near field up here. And so it's actually going to obscure some of the true reflections that should be in that area. So on your picture, once you put the probe down, if you cannot see 1, 2, 3, 4, 5, 6, 7, 8, 9, there's 9 pins. Those 9 pins, if you can't see all 9 of them, it tells us where the dead zone is. So maybe you can only see down from pin number 4 and on. That would mean that we're missing this first little bit up here. So the dead zone tells us how much of that near field are we actually missing. The vertical group here, this part here shows us, can we register echoes all the way through the vertical portion of the image. So it tells us that. It also tells us, can we register the appropriate distance between each of these dots through the vertical part of the image. And the other thing you'll see, I'm going to jump back to the picture prior. On that vertical part, what you'll see is that we can see really thin dots up at the top here. But look, as we get further into our field, we start to get wide kind of dashes. And we can see that our focus is right here. So look what's happening. Right at our focus is where we're getting that best reflection. And then they start to get wide because lateral resolution is worsening. So those vertical dots not only tell us about vertical registration, but it does actually give us an idea about lateral resolution. So lateral resolution and vertical registration. We also have this horizontal group. We have a set here in the far field and we have a set up in the near field. So we want to make sure that we can see side to side in the picture, that we can see all 5 of these pins. And then we're going to see a little bit more information about the axial resolution, about how these kind of spread out. Another interesting spot is this kind of set of curved pins. When we scan from the top, we can check the axial resolution. What we are looking for is, can we see all of these pins displayed in the vertical plane. Remember, as the pins get closer, they start to be displayed as one if the frequency or the wavelength is too long to display both. So let's take a look back at our other one, at our picture. We had 1, 2, 3, 4, 5, 6 in the vertical. We'll go back to our picture here, and we can see 1, 2, 3, 4 clearly, and then 5 and 6 kind of start to mesh together. So that shows us how our axial resolution is unable to produce individual dots. When we scan then from the top as well, we can also check our lateral resolution. Remember that side to side stuff. So now we're looking at 1, 2, 3, 4 distinct dots, but the number 5 and 6 start to kind of blend together. So our tissue phantom shows us on the map that these two dots right here, these two pins, they are way too close to be displayed as independent pins, even though they truly are. So that just kind of gives us an idea of how the axial and the lateral resolution are affected by the transducer selection or by the focal point, wherever that is placed. Over on the other side here, we're going to have these bars that run through the tissue phantom. And typically, you're going to have a bunch of bars of different sizes. You're going to be told what those sizes are, so 8, 6, 4, 3, and 2 millimeters. So we should be able to measure an 8 millimeter structure here in the near field and an 8 millimeter structure here in the far field. It shouldn't matter where we are in our field. We should get 8 millimeters no matter what. That's testing the accuracy of the machine. Same idea down to the 2 millimeters. 2 millimeters, I would say, is kind of the cutoff for most machines for being able to detect a structure, a prominent structure. So that 2 millimeters, we want to make sure we're getting 2 millimeters in the far field, same as 2 millimeters in the near field. To test the uniformity of the grayscale component, then we're going to flip the phantom onto its side, and we're going to be coming in from this side. So what we are going to be looking at then, we want to make sure that this first structure is solid and anechoic, very bright, and then we want to make sure that this last structure is, bright and hyperechoic. This last structure should be anechoic. We want to make sure that we don't have misregistration of grays in a bright spot. We also want to make sure that we don't have this anechoic structure appearing with echoes within it. And then we have kind of spaces in between here that tell us that we should progressively be getting darker. If these are all the same level gray, then something's wrong with the calibration of our machine. So this again tells us that we're going to get the right grays for what we expect on the machine. So again, we're going to cover a lot of these as we talk about what it means to test each of these in a minute here. But the biggest thing to know is really follow this roadmap, know which each of these are testing and why we need this roadmap. Now, another type of phantom that we have is called a Doppler phantom. And Doppler phantoms allow us to test the Doppler instrumentation on the machine. So that would be the pulse wave Doppler, the continuous wave Doppler, and the color Doppler, and the power Doppler. The Doppler phantom has to have something moving in it. Remember that Doppler instrumentation detects movement relative to the sound beam, and so we need to have something moving within our Doppler phantoms. Flow phantoms are the preferred method. They basically have a tube within them and a pump. The pump will move fluid through the tube at a set rate, so you always know it's moving at 75 centimeters per second or something like that. And then you can test, are you getting the right color flow, the right color direction, good registration of the color, is all of that working? And so the flow phantom is the preferred method to test our Doppler instrumentation. The other couple things that are out there, a little bit older versions of phantoms, are vibrating string phantoms. Remember, the vibrating string is going to cause some movement within the structure so the machine can pick that up, or an actual moving belt, which can provide that Doppler shift so the machine can detect it. So again, Doppler phantoms have to have something that is moving within to test the Doppler function. The last type of phantom that we talked about then is the slice thickness phantom, or the elevational resolution. So with the slice thickness phantom, or the beam profile phantom, it's going to allow us to see the shape of the beam. So what these look like, they again kind of are made of that soft tissue jelly material. And through the middle of it, we'll use this one down here, through the middle of it is this flat bar. And you scan from the surface that's 45 degrees to the bar. You scan with the surface that is parallel with the bar, and it will tell you different information about each one. So we can tell on this one up here that we are getting our slice thickness measured in this one. So this image is being taken from the 45 degree scan plane. So what's happening is that the beam is heading into the tissue, it's interacting with the bar, and what it's telling us is how much of that bar is being seen. So we can go in and we can measure from side to side on this image, and it would tell us that our slice thickness is actually 1 millimeter, 2 millimeters wide. That would be our elevational resolution that we are testing with this. Now when we come off to the side here, we would measure parallel with this beam using this kind of slanted corner. And what that's going to tell us is how wide our beam is. So it's going to give us our beam profile. So here we can see it's very narrow in the near field. Continues to be narrow until the focus, which we can see here. And then we can see how it diverges in the far field. So this phantom helps us to determine what our elevational resolution is and what our lateral resolution will be. I also have a slice thickness phantom. Here it is. Come up a little bit more here. So with the slice thickness phantom, we have the flat edge up on top here. So we would image through this edge, and as that sound beam comes down, it's going to interact with the scattering plane, or that flat bar that we talked about. And as it interacts with us, it'll tell us how much of that flat bar can it see, and that's going to tell us then how wide or how tall, what the elevational resolution is of our beam. We then come off to this angled side here, and we scan in through this part, and that's then going to tell us where is it narrow, does it narrow at where our focus is set, and then we can see the beam divergence past the narrowing or past the focal point. So just kind of interesting way to actually view the true thickness of the slice and of the lateral resolution as well. And again, it's kind of made of that tissue that kind of resembles soft tissue. And you can kind of see here, there you go, you can kind of see that there. You can see the edge of the scattering beam there, so you know where to line up when you're doing the beam profile imaging. Over the next few slides, we're going to talk about some of the things that we can test with our quality assurance program using our phantoms, specifically probably using the tissue equivalent phantom. The first thing that we want to test is the sensitivity. And the sensitivity of the machine is the machine's ability to detect weak echoes. So we want to set the machine up in a couple different ways. The first way is to set it up with minimum tools, or minimum power, minimum gain. What can we detect with the minimum part of it? And then we want to use normal settings, and then we're going to increase everything to the maximum power, the maximum gain, and then we want to observe what our sensitivity is to echoes with maximum. So we want to check on its minimum, normal use, and maximum use to detect weak echoes. The next thing that we can detect with the tissue equivalent phantom is the dead zone. And we talked about this a little bit. We talked about that we want to test the ability of reflectors in those first few centimeters to be displayed. Just getting out the phantom again here. We'll head over to that side. So, that's a little blurry. It'll work. Okay, so we have our dead zone. Again, we are looking for little pins that are up near the first few centimeters of the phantom. So we're looking at these pins right here. Again, there's 9 displayed here. We want to see when our first one comes in. We can also check to the accuracy of the machine in that very near field. We can see from the map on here that these are 5 millimeters apart. So our dead zone becomes deeper as the transducer becomes less effective. So if we have a really, really deep dead zone, it might actually be a transducer malfunction versus something going on with the machine itself. The next thing we can test is registration accuracy then. So we want to be able to accurately identify pins no matter where it is located within the field, near field or far field. And we want to make sure that we are getting the correct size, no matter if we are in the near field or in the far field. So range accuracy is also known as the vertical depth calibration. Remember, range usually goes in that vertical parallel line. Knowing that we have accurate measurements is going to be part of creating a diagnostic image. If we are constantly measuring far field structures as inaccurate, being like a millimeter, a centimeter off, that's a big deal. We want to make sure that we are always having the correct measurements, the correct identification of structures, no matter where they're at within the imaging field. So heading back to our map here then. Our vertical registration are these lines going down here.